All right, so today we are going to spend much of the day uh, on discussing strategy in which individual states could potentially undertake major uh, reform of their individual healthcare systems within the states and possibly groups of states, attempting to um, sort of extricate themselves from the US healthcare system due to acknowledged problems with coverage, cost, and outcomes, and establish their own systems. And we therefore have several individuals who are going to speak in favor of that this afternoon, and other people who have a more cautionary attitude toward that type of intervention and reform strategy. And it is my pleasure to introduce at this point our two speakers who will lead off. And Judy Albert and Claire Cohen will be those two speakers. And Claire Cohen is an African-American child and adolescent psychiatrist who's been practicing in the vicinity of Pittsburgh for the last 30 years. She grew up in Philadelphia, attended Hahnemann Medical College, now referred to as Drexel University Medical School, and did her General Psychiatry Residency at University of Chicago. Thereafter moved to Pittsburgh to do her Child and Adolescent Fellowship at University of Pittsburgh Western Psychiatric Institute. She became attached to the area of Western Pennsylvania and has practiced there since, having worked in a variety of settings, including community mental health clinics, partial hospitals, school-based settings, and currently an inpatient hospital setting. Dr. Cohen has also been active in her community in supporting the strike of the Pittston coal miners. In 1990, she was a member of a group that fought to get a civilian police review board in Pittsburgh. More recently, involved in efforts to stop the school-to-prison pipeline on the Pittsburgh Public Schools, and is a founding member of the Pittsburgh Green New Deal. On the advisory board of the Pittsburgh Black Workers Center, a member of the Doctors Against Genocide, and is fighting for Medicare for All as a member of National Single Payer, PNHP, and the Western PA Coalition for Single Payer Healthcare. As a member of National Single Payer, she's in the committee working on developing a model bill for the implementation of a single payer healthcare system in the U.S. She's a Quaker, member of the Pittsburgh Monthly Meeting, where she's currently serving on the Peace and Social Concerns Committee. Also serves on the Peace and Justice Committee of LEYM, which she can tell us about, and is on an at-large representative to American Friends Service Committee. So welcome, Claire. And
welcome.
Cohen.
Just one correction, you made me younger. I've actually been practicing for 40 years. I can't believe it. But
Uh-oh, this is
40
serious.
years.
All right, well, welcome.
Welcome.
Now I shall attempt to find Judy Albert's bio, which she did send to me. And here we go. I think I'm seeing it. Judy is also an active member of National Single Payer. And hold on just one second. I should be at her bio. Well, now my dogs are acting up. Judy, I'm gonna go calm my dogs on. Could you give your own bio? Because
Sure.
it's gonna take a sec. I'm gonna get on mute for just a second.
Okay.
Yeah, go right ahead. Hold on.
Can you guys hear me? I can't. Okay. So I am a retired physician. I was trained in obstetrics and gynecology and reproductive endocrinology. I went to medical school at the University of Cincinnati, did my residency at McGee Women's Hospital at the University of Pittsburgh, and my fellowship training at the University of Pennsylvania. I was a faculty member at the University of Pennsylvania until early 1990s, when I went back to Pittsburgh and established an independent private practice with another woman, and practiced there in the subspecialty of reproductive endocrinology and infertility for about 30 years. And I've been retired. Unfortunately, my partner was diagnosed with ovarian cancer, and we sold our practice to the University of Pittsburgh, which became an untenable working environment for me as someone who likes to advocate for autonomy in medical practice. And so I've retired. That has allowed me to spend more time advocating for a national single-payer health insurance program, starting with my joining PNHP and the Western Pennsylvania Coalition for Single Payer in about 2015 or 16. I was a national board member at PNHP in 2022 to 2024. I think I might have those years a little bit off. And then I was involved in establishing national single payer, which Claire is also involved in. And I think that goes back to about 2021. I know that our first meetings were some of them were during the pandemic. So I remember that. And so we've been working at national single payer with a very small group of dedicated activists on our steering committee. As Claire mentioned, there is a project to write a model bill for national single payer. And we recently had a successful campaign for a National Day of Action on May 31st, which took place in 25 cities, co-sponsored by 140 organizations across lines of community organizations, single-payer groups, environmental activists, and many others. So that's what we've been doing. And if it's okay, I will just go ahead and start. Our plan was that I was going to present first, and then Claire will present second, and hopefully generate some questions among the interns. So good morning. I hope everybody is here and able to do what they need to do, and also get on Zoom. I'm really thrilled to be invited to talk about this important issue. I've been hearing about the summer internship program for several years, and it's really exciting to be able to participate now. One thing I didn't mention is that I previously lived in Pittsburgh, but in retirement, I have moved to Vermont. So I also share some state of residency with both Betty and Marvin. Although we haven't seen each other in person, we've, like everybody, carried on some relationships on Zoom. So as I mentioned, I've been working with National Single Payer for 4 years, and I think it's important to say what we do. We are a national grassroots organization that organizes locally in the struggle for national single payer healthcare. We are united by common principles that healthcare is a human right, that it must be free from corporate profit, and must be achieved through national legislation. So Dr. Cohen and I have been asked to talk about why we support national legislation rather than state legislation, as Marvin has described. So to be clear, we believe that all the activists who are working for state single-payer bills are working toward the same ultimate goal as we are, which is a national health plan. And we have much in common. But this is a very long struggle, and we believe that our limited time, personally, and resources should be focused on the one big goal of national single-payer healthcare. To start, I'd like to briefly review where we are and how we got here. I assume that you've already heard some of these things, but I think it's important just to emphasize what the particular chaotic situation that we're dealing with is, and a little bit about how we got there. So in September of 2024, the Commonwealth Fund released its 8th report comparing healthcare across 10 developed nations. That would be the United States, Canada, Switzerland, Sweden, the UK, France, Germany, Australia, New Zealand, and the Netherlands. And as you probably are aware, every one of these countries, except the United States, has some type of national health system in place. They're not all the same, but they are very distinct from the hodgepodge of our non-system here in the United States. And I am going to drop a link to that report in the chat. And as I mentioned, I may not have mentioned this, but they've been providing these reports for usually about every other year, but this was the 8th one. And they have called them this one is called Mirror 2024, where we are in healthcare. So the highlights, without getting too involved in the report, were that the United States ranked dead last amongst these 10 other developed nations in overall performance. And some other highlights: Americans live the shortest lives and have the most avoidable deaths compared to the other 9 nations. Americans face the most barriers to accessing and affording healthcare. Health system performance compared to spending is the lowest for the United States. Healthcare spending as a percentage of GDP from 1980 to 2022 was the highest for the United States, and healthcare system performance compared to spending was the lowest for the United States. So how did this happen? Just briefly, I think, with the way that the media has been covering the changes to Medicaid and the big beautiful bill that has just passed, everybody has a better idea of where we stand in terms of the desperate needs of our patient population in the United States. We started off in 1965 with some good intention. In 1965, the passage of the Medicare Act occurred, and it was tied to the Civil Rights Act because states could only get the money for Medicare if all the hospitals complied with the civil rights law. And what that meant was that almost every hospital in the United States was desegregated, had to be desegregated in order to get the money to provide Medicare. And this happened because the civil rights movement had developed a degree of power that was sufficient to pressure these hospitals to desegregate. And even more importantly, they were able to enforce the accountability of the hospitals through grassroots organizing that was occurring through the activists in the civil rights movement. And I think it's really important to emphasize the importance of how this happened. The civil rights movement created the political will to desegregate the hospitals across the nation and pass perhaps the most important safety net legislation ever in this country. And while there are many things not to like about Medicare today, it does remain as a template for a national system for supplying healthcare to a group of people who don't have to qualify it other than through their age. It was created with everyone in mind, and once they turn 65, they qualify. And I would like to also make you aware of a way that you can learn more about how the civil rights movement was so deeply entwined with Medicare. There's a wonderful documentary film called Power to Heal, Medicare and the Civil Rights Revolution. And I will drop a link to that in the chat as well. It's an emotionally affecting film, and interestingly enough, it is narrated by Danny Glover, who later became a pitchman for Medicare Advantage, advertising the insurance companies that provide Medicare Advantage, unfortunately. So in 1965, unfortunately, there was not enough political will to extend the coverage to people under 65. So Medicaid was handed to the states to administer. Medicaid has always been a means-tested program. That means you have to prove your eligibility, and that requires that you prove that you are poor enough or disabled enough in order to deserve Medicaid coverage. And obviously, with the big, beautiful bill, there will now be work requirements and an administrative burden that is going to deny care to millions of people in the United States. There are a handful of states that have resisted the managed care schemes of private insurance in their Medicaid programs. And many of those states, people are pretty happy with their Medicaid. However, most of the states, governments have opted to hand over management of benefits to private insurance HMOs that can profit on Medicaid by denying care or using narrow networks. The focus of health policy since the 1960s has really been about controlling costs. The common principles here were the decision to treat healthcare as a commodity, to be subjected to market forces that could, through competition, rein in costs, and the concept that fee-for-service transactions should be managed by an outside force to control the overuse of services. I'm hoping that through the internship so far, it has become clear to the interns that it's pretty difficult to manage healthcare as a commodity. Commodities imply that people have the freedom to choose what they wish to buy, when they wish to buy it, and where they wish to buy it. And when you have a life-threatening illness or even a non-life-threatening illness, you really are not in a position to search for a place that you can get the best deal on a healthcare provision. So this idea that healthcare is commodity is really what has underpinned the whole healthcare system in the United States and led us to this position where we are overly controlled by corporate interests. The march to these corporate controls began in the 1970s, really, when the HMO Act was passed by the Nixon administration. Marching through the 1980s and the era of Reaganomics, private competition was a feature of cost control. In the 1990s, the costs for insurance began to be shifted to consumers with the idea that people were using too much healthcare and they needed to have some skin in the game. So the idea of co-pays and deductibles became popular amongst the insurance providers for employer-based health insurance in an effort to reduce costs. Unfortunately, it didn't reduce costs. And finally, in the early and late 2000s, health insurance really had become unaffordable. And we had the Obama administration determined to fix that. And what they did instead was abandon all discussions of a single payer system and instead enacted the ACA, which we have today. And what this did was basically subsidize private insurance and led to the massive consolidation of the whole medical insurance complex, medical industrial complex that controls healthcare today. The ACA also created the Center for Medicaid and Medicare Innovation, which has been excuse me, headed by individuals who were hired from the insurance industry. They've piloted hundreds of programs designed to save money and improve health outcomes. And mostly they use versions of managed care and then more recently, value-based or accountable care. And this is where the infamous ACO REACH programs originated that essentially punish providers who care for sicker populations. And specifically using this program for traditional Medicare enrollees removed the ability of traditional Medicare subscribers from making their own decisions about where and how they receive their care. And then finally, Medicare Advantage, the private system that is overtaking traditional Medicare, has been granted excessive power by its lack of accountable regulation by the federal government. Medicare Advantage is supposed to comply with the standards of traditional Medicare. And while that is not happening due to excessive denial of care, unfortunately, the federal government has not been enforcing their own rules. So what we're seeing is that now many of the largest health insurers make most of their profit from Medicare Advantage plans. And some of them are withdrawing from the private-based employer delivered health insurance because they can make more money on Medicare Advantage. So what we have in 2025 is a mishmash system that we just really can't tweak anymore, because all the tweaking we've done has simply added one middleman after another into the space, seeking a new way to market. And we've got middlemen in the pharmacy benefit managers space. We've got middlemen in electronic medical records. We've got middlemen figuring out how to manage care with denials, and the list goes on and on. So I think it should be clear that we are facing a huge behemoth of profit and corporatization in the healthcare system. So how do we go about changing this? Well, I think that all of the organizers for Medicare for All, whether they be national single payer or state-based plans, supporters, that we all are really looking for the same thing. We understand that we need to get profit out of healthcare and put people first with a national single payer system as the final goal. At our national single payer organization, our sole focus is to bring this change about at the national level with public funding of comprehensive coverage that extends to all residents from birth to death, including vision, hearing, dental, and long-term care. Our comrades in the movements for state single payer are focused on bringing healthcare coverage to the residents of individual states where they organize. I can't necessarily speak for all these organizers, but my belief is that the movements for state single payer began because of frustration with efforts at the national level and the belief that once several critical states had success with a plan, that the remainder of the states or a significant number of states would quickly follow suit, and that would lead to a fully integrated national single payer system, sort of like Canada. So state single payer supporters all want national single payer in the end, as supporters of national single payer are pushing for as well. Why should we fight national single payer and skip the state-by-state strategy? This is the question that we have been asked to address. I think the number one reason is that we are facing a huge fight. The medical industrial complex is our biggest obstacle, and it's unlikely that any single state can successfully take it on. The barriers are simply greater for state single payer than for national single payer in terms of how are you going to pay for it. We've allowed healthcare to be treated as a commodity, and we created a marketplace where it's sold by an insurance industry that profits with no accountability. Industries making billions in profit will not go down without a fight. And as I think the demonstration of the original passage of Medicare with deep assistance by a deep movement for civil rights in this country illustrates, and Dr. Cohen is going to talk some more about this, we need a unified effort across the country. One of the barriers to states adopting single payer is that they do need to have waivers in order to receive the funds that they're entitled to for running their Medicaid programs and their Medicare programs. And as my colleague Kate Tillow has written in an article published about a year ago in Common Dreams that was entitled, "Don't Bust Up Medicare and Hand It to the States," because Medicare is a federal program and Medicaid receives federal funds but's managed state by state, any single state needs to receive the waivers from the federal government to give them the funds they would need to cover their residents' health needs. Kay was concerned about something that was brewing in federal lawmaking when Massachusetts Senator Ed Markey introduced a bill in the Senate in 2024 called the State-Based Universal Health Care Act. And this is a companion bill to one that had been introduced in the House by Ro Khanna the previous year with the same name. And these bills are similar. They allow states basically to use federal funds to create model plans that are required to cover 95% of the residents of their state within 5 years of onset of the plan. And, you know, one thing I would point out is that covering 95% of residents is something that already exists in many states. And so it's a rather low bar for states to comply with this requirement. The bills do not have much in the way of specificity. And they, in fact, they stipulate that any new state plan would have to provide the same benefits as Medicare. But as I've pointed out, we don't have a good track record of holding states or plans accountable for providing the same benefits as the gold standard that Medicare is. And this is borne out in how Medicare Advantage has been allowed to profit excessively. We think that we don't really need another experiment or model in a state system to show how it can be done. And in the setting of the Commonwealth Fund report, we could see that there are plenty of models for national healthcare systems in other economically developed countries that are quite successful in terms of health outcomes and in terms of cost containment. They spend less, they have better health outcomes. So the problem is not really the lack of a model, it's the power of the industry. Neither of these state-based universal healthcare acts say that the plan that any state adopts would have to be a single payer plan. Multi-payer systems would allow profit to stay in the system because the single payer is assumed to be public monies from the government, and multi-payer systems mean that you will have multiple payers, some of whom will be private insurers. And it seems that this would just encourage privatization and continue the administrative burden, which means that you're not going to save money. So it doesn't fix the profit problem. And yet state bills have allowed for multiple payers by necessity due to the high cost of trying to cover a state on the limited budgets that states have. And as Marvin will talk about, I think later today, states do have requirements that they keep a balanced budget. This is not the same as the federal government, which is not required to balance the budget every year. So it's a constraint on providing health care that states will have. And, you know, finally, if we have to go ahead and and write new bills to change national laws, such as these two bills, one in the House and one in the Senate, are trying to do, why not do the whole thing? Why not create a national single payer plan, do it right, and get a national single payer system? It's a monumental fight, and incremental changes like state single payer, we feel, are just an unnecessary delay on the way to what we really need. There are also some reasons why we feel that state single payer, state-based single payer, or state-based multi-payer universal coverage systems would be a step backwards. We have seen that states sometimes make bad choices when federal laws are lifted. Most recently, with the Dobbs decision that removed the federal protections for abortion rights, Republican state legislators have enacted extreme anti-abortion laws such that women are treated unequally depending on what state that they live in. There are also workers' comp and unemployment laws that vary state by state. So states can determine what the degree of support for unemployment compensation is required by employers within their state. And if a state has is more favorable to an employer because there are lower levels of requirement for insurance for an injured worker, businesses might choose to locate in the states that have less strict workers' comp employer requirements. In some cases, there's extreme pressure on lawmakers to change laws in their favor. We don't want to put healthcare in competition between states because it would just make healthcare more vulnerable to attack. With a national plan, everybody has a stake in the healthcare system, and it's more difficult to pit states against each other or pit various groups against each other. And then finally, the Voting Rights Act, which was the landmark civil rights legislation passed in 1965, was gutted in 2013 by the Supreme Court decision that paved the way for some states to ignore the guardrails that had been put in place for voting rights. And indeed, states decided they would take advantage of this and remove the protections for voting rights that had been enacted as part of the civil rights movement. And then finally, the question of the domino effect and whether state-based systems being enacted in the United States will follow the pathway that occurred in Canada. So in Canada, health coverage started in, or at least the drive for healthcare coverage started in the province of Saskatchewan in the 1950s and 60s when healthcare became an issue after 2 world wars and the inability of Canadians to sufficiently cover their costs. It took a long time. It wasn't something that happened immediately. But once Saskatchewan came up with a plan, the remaining provinces followed suit. And the federal system requires that the provinces have healthcare coverage. But still to this day, the coverages are different from province to province. Canada has, I think, only 10 provinces and 2 territories, which is a much different situation than we have in the United States. And perhaps most importantly, when the Saskatchewan healthcare provincial system was enacted, there was no existing federal plan that had to be broken up in order to get provincial healthcare. In other words, they didn't have to get waivers as states in the United States would have to get, as I had discussed previously. So we don't really have evidence that there's a guarantee that one state would follow suit after another in the United States. And also based on the experience that we've seen with things like Medicaid expansion under the ACA, where states were given a gift from the federal government to expand their Medicaid programs to cover more people. And, initially 15 states for for quite some time, refused to do the expansion. Now that has changed and it's a little bit better, but again, Dr. Cohen's going to talk a little bit about how this has had will have an impact going forward on equitable distribution of healthcare in the United States. And I think it's an example, again, that state governments are operating under quite different political mindsets. And there will always be states that would never opt in for state health coverage. In summary, I feel like there are very compelling reasons to continue the fight for national single payer and not be distracted by lesser incremental goals. The pivot to support state single payer seems to be based on frustration and perhaps despair. Then in nearly 40 years of activism, we still don't have universal coverage. Obviously, it's understandable that we're frustrated. It's a long struggle. It's going to span many election cycles. It's going to span generations. State plans are supposed to create a model for how a national plan would work. We don't need models. We know what the model is. There are models all over the world for national single payer plans, and they do perform more efficiently than our privatized system. We know this. We need to understand that the insurance industry and the whole medical industrial complex has dominated the media, academia, research institutes, HHS, and of course, the Center for Medicaid and Medicare Services. The Center for Medicare and Medicaid Innovation. So this is a huge behemoth, and we need a much bigger movement to fight this power of the healthcare insurance industry, and it needs to include everyone in every state. If we all really want national single payer, then we need to demand it. Incremental changes just create unnecessary delays. And as Frederick Douglass said, power concedes nothing without a demand. It never did and never will. I think we know what our demand is. So thank you for listening, and I'm going to turn it over to Claire, who will give us some more insight as to the support for national single payer.
Okay. I want to focus on the fight for single payer healthcare in the context of the racist socio-political culture of the United States and how the legacy of racism at every level of our society has historically and continues currently to promote and perpetuate racist social policies most effectively and persistently implemented on the state level in the name of states' rights, from slavery to segregation to voting laws to welfare policy to criminal justice laws and policy and to healthcare. Furthermore, I believe that in developing an effective strategy for obtaining a single-payer healthcare program in the United States, while we can look to Canada's history for some guidance, we must take into account the deforming impact of our own racist legacy to be successful. If we do not take that legacy into account, we will have unintended consequences that lead to decreasing health and decreasing healthcare equity in the United States. There are states that have a history of progressive programs and policies, but these are not the states that have the greatest proportion of Black people or of other people of color. Historically, there are states in what is known as the Black Belt South, which have tended to have reactionary governments due to the ruling classes in those states having been successful in creating a culture in which the majority of white citizens, including those in poor and working classes, have bought the idea that it is not in their interest to have an equitable society with universal coverage of any type of social safety net, including healthcare. They have bought the idea that there are two classes of people, deserving and undeserving. And that is why these states have less strict worker compensation programs, more restricted voting rights, and adequate welfare benefit coverage for poor women and children and even single adults, and more draconian juvenile justice laws and policies and criminal justice laws and policies in general. This is why that to this day, there are still 10 states that have not implemented the expanded Medicaid that was supposed to be under the ACA. 8 of those states being Black Belt states. And those states will never implement that unless they're forced to. This is why 4 states, Mississippi, Alabama, Georgia, and Arkansas, have the least generous welfare benefits in the nation. The 10 states with the most generous social and welfare policies in the United States are Massachusetts, New Mexico, Alaska, New York, Vermont, Rhode Island, California, Minnesota, Hawaii, and Connecticut. That's not ranked by order because if you look the information up, different states are ranked differently. The Black Belt South states are Alabama, Arkansas, Florida, Georgia, Louisiana, Mississippi, South Carolina, North Carolina, Tennessee, Virginia, Maryland, and Texas. With the exception of Texas, they were originally called Black Belt due to their very, very rich soil. It later came to mean states with the largest enslaved populations. Thus, that is how Texas got included, because Texas eventually became the state with the largest enslaved population that got emancipated the latest. That's how we come to Juneteenth. With the exception of Maryland, these states have traditionally been states in which there was a culture of identifying groups of people as being deserving versus non-deserving, largely based on race and ethnicity. The upper classes in these states have actually seen it in their interests that, as a part of their strategy for accumulating wealth and power and sabotaging class struggle to keep the poor and working classes racially divided. Thus, having worse health statistics and health care statistics in these states as compared to other states has not been a concern for them. They have convinced the white population, including the working class, that these poor statistics are due to some innate natural law of the Black population themselves, and some instances, the brown population, not a manifestation of public policy. I want to use as a cautionary tale the example of the welfare system in the United States. Until 1996, our welfare program was called Aid to Families with Dependent Children, AFDC. It was a program that was not exactly like Medicare, but it was basically federally administered and federally funded. The federal government determined what the benefits were for families, and it did include some variation for states based on their economic situation. Although there are legitimate critiques that can be made about some of the policies behind the AFDC program, it was basically equitably administered across the nation. In 1996, President Clinton changed the welfare system by getting rid of AFDC and changing the program to a program called Temporary Assistance for Needy Families, TANF. The big difference in that program was that instead of a federal program overseeing state benefits, it became a block grant program similar to Medicaid, in which states were given great flexibility and leeway in how in administering the program and determining the benefits. This was supposed to improve the welfare benefit system in the United States. In March 17, 2023, the Center on Budget and Policy Priorities put out a report that pointed out that due to this change, promoting broader flexibility for the states, the extreme poverty rate in the United States had actually worsened because many states that use that flexibility to divert funds away from helping the poor into other state budget priorities. Things like pre-K, universal pre-K, which is good in and of itself, but also state vouchers for private schools and so on. In 2021, of the federal government monies given to the states, only 1/5 of it was being spent on providing aid to needy families. 4/5 of that money was going for other budget priorities. In 14 states, less than 10% of the funds was spent on providing benefits for needy families. As a result, the level of what's called deep poverty in the United States has increased and fewer families receive benefits. And deep poverty means households with incomes less than 50% of the poverty level. And that is why you hear of things like people selling their blood so that they can cover their household costs, they can cover their needs. In addition, other studies have shown that TANF is structured in such a way that it actually makes it more difficult for people on it to get jobs that lift them out of poverty. That's a subject for another talk. Back to healthcare. In November of 23, Representative Ro introduced the State-Based Universal Healthcare Act, followed by Senator Markey introducing a similar bill in the Senate in April of 2024. And these were bills that gave states that wanted to do single payer waivers, because one of the problems that states wanting to do single payer, as Judy has told you previously, was that they can't get all the monies they need to implement single payer programs for all of their population. And they have fixed budgets. They can't go over budget like the federal government does. So these bills would allow states to get a hold of the Medicare monies for their populations, and use them flexibly for a program, innovative program to improve healthcare in the state, as long as it covered 95% of the population, as she said. But none of these waivers stipulate that these monies must be used for a single payer system. Yes, if these waivers are passed, they could enable some progressive states to implement state-based single-payer programs. But the reactionary states that I mentioned above, with reactionary governments, which includes the Black Belt states, and will be just as likely to use these waivers to more and deeply embed private insurance in their healthcare systems, thus decreasing access to healthcare coverage and increasing healthcare and healthcare coverage inequity in the United States. These states have no interest in following along with those states that have a single payer system, just like they've had no interest in getting rid of slavery when there were some progressive states in the North that got rid of slavery and freed their slaves. And I could go on and on with other examples. As another cautionary tale, Arkansas and Georgia respectively implemented work requirements for Medicaid in June 2018 and July 23. Once again, the Center on Budget and Policy Priorities put out a report determining that both programs have been a failure and that they have actually cost these two states to have to spend more money on health care, on their Medicaid program, in other words, while causing thousands of people to lose health care coverage. And why more money? Because they have to have these programs to make sure that people are meeting these work requirements. They have to hire these people, they have to have computer programs, so on. And it's not an easy job to do. Despite this, the federal government, it's not, at the same time, I should go back and say, at the same time or not at the same time, within a similar time period, the states of Maine and Connecticut looked at their Medicaid programs, okay? One of the things that's happened in the United States is that many state Medicaid programs have been convinced that they need to privatize their Medicaid programs, do what's called a private-public partnership, because supposedly this would make their programs more cost-efficient and more of higher quality and effective and cover more people. Well, there was a report put out by the Commonwealth Fund, which found out that wasn't true. All of these states that did this went on to have studies to look and see if this was really true. And that was not true. Implementing privatization of Medicaid has made it less cost effective and the programs of poor quality. Two states, upon recognizing this, Connecticut and Maine, decided to deprivatize the Medicaid programs, make them back to be fully public programs. And what happened? They went to the top of the list as the Medicaid programs that are most cost effective with the highest quality health care. Have other states followed through? No, definitely not the reactionary states. Despite this data demonstrating this, they have not said, oh, look at this. We're going to now deprivatize our Medicare. If anything, they're going in the opposite direction. I look at my own state, which is not considered a black belt state, Pennsylvania. Is Pennsylvania deciding to deprivatize Medicare? I can tell you in my state as a physician, no. If anything, they are more deeply embedding privatization in Medicare. So this idea that because some states do a very progressive thing with their social benefits and then demonstrate that it has been to the betterment of their citizens, it has been more cost effective, it has ended up with better health care, that other states will necessarily follow behind. That doesn't work in the United States. And a lot of this is because of our racist legacy, and it is an error in strategic thinking to assume that the success of individual states in implementing single-payer healthcare systems will inspire other states to follow. States certainly, if a state wants to pursue a state-based system and believes it's in its interest, fine. I'm not against that. And I don't think any of us in the national system are against that. We're not saying, oh, that's not good to do. We're just pointing out that it's a fallacy to think that that will automatically lead to the whole country having single payer coverage, and that it will inspire other states to follow. And also, given the Trump fascist administration, I think it actually these waiver programs are actually dangerous, because I really believe that the Trump administration they're not dumb. They will see that that is a good tool to dismantle Medicare. A little known fact is that the ACA, when it was implemented, had a clause in the act which set up the Center for Medicare and Medicaid Innovation, which set up the ability for that center to implement, quote, innovative programs in Medicare to improve the efficiency of Medicare without being vetted or monitored by Congress. And the Trump administration used that clause to introduce private equity into Medicare. And we are fighting that today. We are fighting to keep private equity from having a major foothold in Medicare. So I think that it is very important. We all want a single payer healthcare program in this country. We need to think about not only just what we wish and like, but we need to be aware of what the other side is thinking and how it's looking at what we're doing, because certainly it looks at how it can use what we are doing to further its ends, which are not for single-payer health care and certainly not for universal health care. And it's not a matter of whether you're my friend or you're my enemy. It's a matter of thinking strategically. How do we get what we want without inadvertently ending up with unintended consequences? So I have about 10 minutes left before I have to go to my treatment team. So hopefully there's enough time to have for some questions.
Thank you so much. Really appreciate your time and your perspective. Marvin, were you planning to moderate here? I see you're still muted. I'm happy to moderate if that's helpful to you.
Yeah, sure. We have scheduled until 10:15, I think. So we do have some time for some questions. And I guess I'll start off with a question. I'm wondering if you see you indicated that you see no problem with states establishing healthcare systems, and I'm wondering to what extent you're worried that the reaction in the opposite direction may actually be harmful. In other words, if a state is empowered to deconstruct, all the waivers that are required to create a state-based system would basically deconstruct a lot of the institutions in place, Medicare, ERISA, even the way Medicaid functions, and the ACA. So, you're sort of deconstructing every single major aspect of our health system. And I'm wondering if you think it would make it more difficult for people who support the deconstruction and wish to replace it with nothing, which is really the whole point of the Trump-Musk administration. It's kind of dismantling institutions and really not replacing them or replacing them with something weak. If you worry that that could be taken up by other states and sort of empower them to do even less for their populations.
So when I say it's okay, what I meant when I say it's okay, if states aren't really interested in having a universal system for the nation, they just want to have a universal system in their state. That's what I mean by it's okay. But if we want to have a universal system for our nation, yes, I certainly think that there's enough history showing that some of these reactionary states, that's exactly what they would do. That's what the Trump administration wants to do. They're not going to sit back and say, oh, well, we'll just sit back and not do anything. They're looking for ways to dismantle what little bit of a Social Security net we have now. And just like they found a way to use that clause in the Affordable Care Act, they'll find it. They're actively looking for ways to dismantle. And they, just like us, know that those waivers will dismantle that little bit of structure we have now. They're not going to sit back and just say, oh, look at what they're doing. And now they're going to use it. And I think that reading some of the very aggressive ways and some of the reactionary states are working on many different levels in terms of social policy, I worry that they will use any chance they get to turn things backwards, to undo many of the progressive policy that we have in their states. And I'll let Julie, you can answer that too, but that's my feeling. I'm very worried about that.
Yeah, I think, we are trying to straddle this somewhat of a divide between supporting state versus supporting national, without impugning the motives of people that are advocating for state single payer. I think the motivation is similar, but I think what Claire brought up is this idea, and Marvin, you put a greater emphasis on it as well. The idea of unintended consequences is something that is blowing up into a whole different ballgame under the Trump administration. It's been happening for years and years, as Claire indicated. I mean, and I mean, just look at abortion. I think that's probably in addition to, but also related to the racial and income disparities in women's health care, abortion and control of women's reproductive rights falls into that same category. And it's a completely different situation now practicing obstetrics and gynecology. Wherever you may be, you are aware, if you are a state that is providing abortion care, you're certainly surrounded by states that don't. And this is just not a tenable situation going forward. And I think, when you think about the rest of our healthcare system, states dealing with what's on either side of their borders is going to be a problem.
Yeah, any students, interns have any questions? If not, we'll take Betty's question. Go right ahead.
Thank you. I would like to clarify that I'm gonna let Ariana go first. I see she's got her hand up.
Oh, it's okay, Dr. Keller. Are you sure?
Go ahead.
Well, I was just thinking about Dr. Cohen, when you were talking about how there are Maine, I think you said in Connecticut, like deprivatized their insurance because of the bad outcomes, and other states have not followed in their lead. And I'm just kind of wondering, with the data that was created, like what are these like states' explanation for not like following in this direction?
I don't know what their explanations are, because the study I read with the Commonwealth Fund report didn't address that. I know that in Pennsylvania, I don't think they look beyond their own state. I think that the policymakers in Pennsylvania, we tend to have a reactionary legislature, and they have certain ideological beliefs and biases, and they function on those. We also have a very corrupted legislature, which is bought and sold by. It's a joke about how the gift giving from big businesses to our legislatures. I think that they feel no pressure. Pennsylvania, for example, every state around it has raised the minimum wage. Pennsylvania has yet to raise their minimum wage, even though there's lots of studies showing the benefits of doing that. And I think as long as they don't feel pressure from the population in the state to do that, to address some of these issues, they're not going to. There would have to be massive pressure, and I think the general population is just not educated on this information. And it's hard to educate because we don't own the airwaves, and we need to do more, or try to do more to organize to educate the population. But and I have family members that live in southern states, Georgia and Texas, and when I go down there, I get the same kind of sense that the states they have their ideology. They're not looking at the whole nation and the population, and they don't feel any pressure from the population. And yes, Zach, you're right. Pennsylvania is still federal minimum wage. I think they might have raised it like by 50 cents or something, but it's not much above minimum wage. So I hope that answers your questions. There's just not a pressure on them to follow the good, and to look at other states and what's worked better and to follow.
Thank you. So I'll go ahead with my question. So my impression, my understanding from all the activists I've spoken to who are working on state-based single payer except for one person, all the ones I know actually are not expecting one state after another to do it across the whole country. They're expecting that when we get a few, that then there will be the motivation to pass a national single payer bill. And then we would have the structure to have the equity and things built in. So it's not like people really think that, oh, Mississippi is going to someday pass its own. I don't think anybody expects that.
Yeah.
However, in the 40 years that we've been, or well, more than that before PNHP, in all these years that we've been trying to get a healthcare system that's equitable and publicly funded and everything, we haven't gotten there. And we can talk about, we can say we have frustration, but also sometimes it just makes sense to look at your strategy. And if your strategy has not been effective, you don't want to keep on doing the same old, same old. So one thing is that if the strategy is to have a national single payer bill passed through both the House and the Senate, especially looking at the Senate, how are we going to get those 51 votes? How, looking at the states, how are we going to achieve that? And so there needs to be, it would be an easier lift to get the state-based one lifted, get people to sign on to that than it would be to get the national single payer bill. So I'm wondering, like, how we really need to do some major outreach into, this black belt, into these states where people are actually and we have to change our culture. I mean, how do we do that? I'd just like to hear your thoughts, Claire, before you have to leave.
So I don't think we're going to do it by having a state pass this national single payer. Okay. Some people who become aware might want to move to that state that has it. But, and just like having some states have progressive, having gotten rid of slavery, or some states having progressive abortion policies. I think the strategy, rather than retreating to try to do state by state, is we need to take a look at how we get things like the labor movement involved. Okay. When we look at the progressive legislation that was passed in the 30s in the New Deal, it wasn't just that FDR came down. It was a strong labor movement that pushed that. And I think that certainly one of the things, and I know our labor movement is weak, but I think one of the things we need to do is look, how do we organize and build that labor movement? The other thing is reaching people of color. If we look at the civil rights movement, well, I'm not saying don't do local organizing, but the local organizing was geared towards changing things nationally. And I think we need to look more at how we do outreach to many of these poor populations, people of color populations, educate them to what the needs are. And people need to be aware. I've realized, because I've been doing a lot of work and with Congress lately under Doctors Against Genocide, a lot of people just are not aware of what goes on in Congress. There's a real disconnect, and helping people to make connections with how what goes on there impacts and affect their lives. So I think I don't have all the answers, but I think those are two things. One, we need to work on getting labor more, because labor it has some power still, getting labor more involved in supporting this, and work on getting on strategies to educate the population. And you can certainly do local education. And one good thing about the state efforts is it educating people locally about what we need. But I think that the focus needs to be on, this is something we need nationally, and what we need to do to put pressures, a lot of pressures. There is the Jayapal bill. It has some faults, but it's basically a good bill. If we galvanize and supported people in supporting that bill. So for example, that was one of the things. That's one of the things, and did put out more efforts to educate people about that bill. Just like people call when they try to get rid of Medicare, all these people call, we could have people calling, hey, I want you to support Jayapal bill.
So I'm really excited to hear you as a Black woman saying that we need to draw out, people of color, because I have definitely also heard from some Black people saying, you as a white person, don't ask us to do more. We are just trying to keep our heads afloat. We're dealing with mass incarceration. We're dealing with so many things that we can't do one more thing. Don't count on us. You do the job yourselves. And so I'm wondering what kinds of messaging you recommend, or where to do the outreach. Just any hints you can give. Thank you.
So two areas of outreach are infant mortality and maternal mortality. Most Black people are very aware of the dire statistics on both of those, and addressing the issue. How are we going to address this? I know there's an effort in Pennsylvania. It's not tied to single payer to address the maternal mortality rate. The gap is so large, especially in Western Pennsylvania, and those efforts are not really, many of the people are not looking at how our healthcare system, our for-profit healthcare system, plays a role. I've tried to get a little bit involved with it. It's a little hard for me because I'm in psychiatry.
Right.
I've been trying to find that Black OBGYN person and Black pediatrician who will join me in the efforts to, I found a Black family physician who'll join me in the efforts to make the case to my fellow healthcare providers that a major piece of closing that gap is single payer healthcare. And I think just doing some that's one thing. Those Black physicians like myself, Claudia Fagan, people like that, who are convinced, what can the wider healthcare movement do to support us, to help us? Like, I'd quit my job tomorrow if I had money, compensation to go out on the road and preach this, But I can't afford to quit my job and just do this voluntarily, no pay, I have to admit. But, if I've often thought of that, could I get a grant or could I get some money to go out and talk? I would do that. I really would. So we need to look at how we can support those people of color who are convinced to go out and do more outreach and talking. And I'm being paid, so maybe one more minute.
Can I
Exactly.
just highlight a really important and positive development in the outreach that PNHP has done. There's a reproductive interest group that Diljit, the president of PNHP, who is an obstetrician gynecologist, and several others. I participated early on when they were, their goal was to reach out and try to organize with one of the main reproductive justice groups in the United States, which is called Sister Song. And they have since successfully had several, I'm aware of at least 2 educational programs that the women from Sister Song, which is created as a group for Black and brown women, and is based in Atlanta. And it's a wonderful example of how that sort of partnership can develop. And I think, kind of feeds into what Claire is suggesting, trying to make it clear that we are working for the same thing, without being proscriptive and telling people what they need to do. As white organizers from PNHP, that's a hard thing to do, as Betty has mentioned. And so it's something to highlight, I think.